There are many questions that could be asked at any time point, so not a question for you may not be the same as question from this side. So it's very important to understand the journey of the patient, why we are doing the Fibroscan, and what question are we answering, and then how does it change over time. And this is becoming very important because of the decompensation where there is liver failure to recompensation where the liver failure has improved, and it is important to understand how much improvement, who is at risk of, who is at risk of decompensation, and who is more prone to recompensate, so we can appropriately counsel the patients. And now on one side, you could just see the fibrosis reversal, but on the other side, you could see the decompensated liver disease recompensating. And this has been characterized in several other diseases like hepatitis B, abstinence from alcohol, where alcohol-related liver disease improves with time. And similarly, even in autoimmune hepatitis, treatment response can resolve the liver inflammation and injury, and one can go from decompensation to recompensation, and from certain degree of fibrosis to a lesser degree of fibrosis. So dynamics of treatment response is very integral to managing patients with autoimmune hepatitis. So there is some data. This is a retrospective study. In this, they looked at people who presented with decompensation. These are autoimmune hepatitis patients who showed up with ascites, variceal bleed, hepatic encephalopathy, and they looked at those who got treated and responded versus those who were not treated. And even in this advanced liver disease, people who got treated and responded to treatment, 36% of them recompensated. So it's very dynamic. There is no such thing as it's too late. There's always a reason to attempt to modify the natural history, and knowing the natural history and characterizing, quantifying the improvement is very integral to management of patients with autoimmune hepatitis. So where are we now? Where were we in the past? Generally, healthy liver, then inflammation, then scar tissue, eventually leading to cirrhosis, and then that is the risk factor for cancer. But this is nothing that has not been recognized in the history. The Chinese have described that hard, palpable liver is a bad sign. And the Greeks have discovered this side where they said a healthy liver is soft. So both spectrum of liver disease has been described from the ancient times, and this was, until I trained, I guess. But now we have a way to quantify the same concept, the stiffness of the liver, but giving an objective number, and that's what is Fibroscan, where you generate a mechanical shear wave. That's the shear wave that is mentioned from blood tests, from biopsy, from imaging. This is another concept that is helping us to get a rounded overview of the liver health. And there's a number that the device produces. Generally less than 8 kilopascals indicates a soft, healthy liver with minimal inflammation and minimal scarring. And 15, the higher it is, it can go up to 75. The higher it is, the more stiff, but that stiffness could be a combination from scarring and inflammation. Now, many of you are from different places, and every place could have a preference to a certain type of device. The Fibroscan is a device that is using ultrasound, but there is MR based elastography too. So if you go to certain Mayo, whichever facility has their device, they're going to use it more. So we do have MR elastography But then you have to order it, it has to be scheduled, and then prior authorization, while the Fibroscan is right there in the clinic, and we can get it done and discuss the results in the same visit. So everybody has a different preference to what they are using. Even in the ultrasound-based devices, there are several in the market. It's a very successful and commonly used device, so obviously there will be Me Too's, and there are Me Too's, they are half the price, but they have never had been validated as extensively as Fibroscan, so the data is not there. It's being sold and being used, and sometimes you are extrapolating the number from one device to the other device, and we don't necessarily know if it means the same. So we are doing some of those studies here at IU. So here, at this time, you can have the liver stiffness measured, which is the liver stiffness measurement, LSM. At the same time, you can measure the spleen stiffness, and spleen stiffness corresponds to the degree of portal hypertension. This is particularly important if somebody has cirrhosis. You want to know how bad is the back pressure from the liver to the spleen, so we can quantify and predict who would have varices, who would be at high risk for decompensation. So through the whole spectrum, from those who have no fibrosis to those who have cirrhosis and portal hypertension, with one device, we can quantify the severity all in one time and have the appropriate conversation. Now, this device also measures the amount of fat in the liver, and we are increasingly trying to investigate the relationship between fat in the liver, autoimmune hepatitis, inflammation, how does it affect the natural history, how does it affect the prognosis. So this is something that we are continuing to understand, but this device gives you that number right away. This is important in those with diabetes, fatty liver, but its role in autoimmune hepatitis is something that we are continuing to understand. But with one test, you have the liver stiffness measurement, SSM, and then the fat measure is called controlled attenuation parameter, or CAP score. A typical report would look like this. So on your left, you have the liver stiffness, the 30.3. That is the stiffness of the liver, and that is high. It could be a patient with cirrhosis, or it could be someone with a lot of inflammation in the liver. This is not a patient with autoimmune, so that that is something to consider. Then the amount of fat in the liver is 326. That's high. Normal is less than 250. Max is 400. So a lot of stiffness in the liver, maybe concern for cirrhosis. There's a lot of fat in the liver. So that gives you an insight right away. And then because we are concerned for cirrhosis, we immediately go and look at the spleen stiffness. That is 78.8. Max is 100. Normal is 21. And anything above 50 suggests that there could be large varices. So this is someone, if I see in the clinic, I'm going to ask for an upper endoscopy right away because we need to know the size of the varices. If that 78.8 was 25, I would say, okay, I don't think we're going to find any varices. Perhaps we can do upper endoscopy at your convenience. The Europeans wouldn't even do an upper endoscopy because they go by the spleen stiffness. Theirs, it's not fee for service, so they would try to find every reason not to do a procedure. So they use every non-invasive thing to optimize the cost of care. So they use it extensively to decide who gets an upper endoscopy and who doesn't. So they have this rule of 5 where, less than 5, it's normal, about 10, about 15, about 20, about 25. So every 5 kilopascal increment, you are concerned about increasing severity of the liver disease. So the field is moving from the biopsy, stage 1, stage 2, stage 3, to Fibroscan with which number do you have, and are you getting higher or are you getting lower with the time? In general, the outcomes are less or near normal if the Fibroscan liver stiffness is less than 10 kilopascal. So several studies are suggesting as long as you keep it below 10, you'll be fine. So do everything possible to bring it below 10. On the other side, you have the spleen stiffness. I already talked about 21 being normal. If it is above 50, it tells us that their portal hypertension is moderate to severe and at risk of outcomes. So how do we interpret Fibroscan results in our patients with autoimmune hepatitis? One thing is different in autoimmune hepatitis is the inflammation. So on one side, you have the inflammation that could be mild to moderate to severe. On the other side, you could have the fibrosis that is mild to moderate to severe. So for example, somebody has a Fibroscan liver stiffness of 10 kilopascals, and inflammation is 0. That means all the 10 kilopascals are being contributed by the fibrosis. But someone else may have the same 10 kilopascals, but inflammation is severe and the fibrosis is mild. That still would give you the same 10 kilopascals. So the inflammation could play a major role in autoimmune hepatitis. That's why when somebody has a new diagnosis of autoimmune hepatitis, enzymes are high, we do the Fibroscan and it shows 25, and they are bawling thinking that they may have cirrhosis, but you have to understand that it is in the context of inflammation. So we would often tell them, hey, this is your baseline. We are not sure if this is inflammation, fibrosis. Why don't we wait and treat the inflammation and redo the Fibroscan before we try to use this as your baseline for fibrosis. So inflammation is something that is very important. Now, other things can increase the liver stiffness, particularly food, recent alcohol. At our institution, we've done a trial where we ask patients to come and go and eat in the cafeteria and then do the liver stiffness every 30 minutes. Regina was foundational trial by Regina and I several years ago, and we saw that the liver stiffness would increase up to the first 2 hours and then come down to baseline by 3 hours. So we have instituted that at least 3 hours of fasting prior to getting a Fibroscan. And if you were to eat, the more amount of calories you would eat, the more liver stiffness it would increase. We saw up to 25% false increase in the liver stiffness after a meal. And sometimes patients say, well, I just had, half a bite of this, and should we make them wait? Should we do the Fibroscan? They drove 3 hours and things like that. So we looked at anything less than 800 calories. It doesn't affect the liver stiffness as much. So sometimes the MA would come in and say, well, the patient ate, what do you want me to do? Do you want me to do the Fibroscan or not? I asked what did they eat, and the MA was like, do you really want to know what they eat? I just told you what they ate. Yes, it will help me understand some. And if it is increased, then I can at least know that it could be a false increase in the liver stiffness from the meal they had. So for liver stiffness in autoimmune hepatitis, I always think, is it fibroinflammation or is it just fibrosis? If there is evidence of inflammation, we always capture the ALT at the time of the Fibroscan. If it is anywhere above 80, 100, then the inflammation is contributing to the liver stiffness. So I'm not necessarily attributing the liver stiffness to the degree of fibrosis. If the IgG is elevated, or if they had a biopsy recently and that shows inflammation, then I would consider this liver stiffness as representing fibroinflammation. But if somebody has a diagnosis of autoimmune for several years, they've been on treatment, ALT is normal, IgG is normal, and liver stiffness is, in my mind, representative of the fibrosis. So the context is important for autoimmune when we are interpreting the liver stiffness in the natural history. So, for example, if this patient with autoimmune is here in the clinic and I'm looking at them and they are a follow-up to me and their ALT is 45, then I'm interpreting this liver stiffness in one way. compared to other numbers. So I look at the basic stuff. How many attempts? You need to have 10 attempts. So that's 4 plus 4 plus 2, that's 10. You need to have 10 measurements for it to be called valid. And there is some quality control, which is IQR over median. If it is less than 30%, then it's reliable. If it is more than 30%, that means that one value is 8 and the other value is 25. If there's so much variability, how are you going to believe which number is right? So that IQR over median tells us that these numbers are very tight and it's less than 30%. So I feel more confident in saying, hey, this is a reliable test. IQR is the lower the better. So I feel more confident in calling it because the IQR is less than 30% and there are 10 values. And then, you know, there's some quality metrics. Some devices have smart exam. If somebody has very broad body wall and there is, you know, liver is deep and they have subcutaneous fat, sometimes this Fibroscan is programmed to measure at a certain depth. And it's going to measure the subcutaneous fat and it's going to call it very stiff. So sometimes you can have very high liver stiffness from Fibroscan measuring subcutaneous fat. So this smart exam is a software upgrade where if it detects that it is measuring subcutaneous fat, it goes a little bit deeper trying to find the liver. So, you know, a facility could buy the Fibroscan, but they may not pay for the smart exam, which is, I think, another $15,000. So you have no idea whether they have it or not, but you could look on the report and it says smart exam, yes or no. So then the newer version has a guided VCTE, which is telling the operator where the liver is. So it's no longer, well, it seems like it is in the liver. It is telling them right now, this is the place where you will get the best results, and it will give them a green light saying that get the measurements right here. So it will decrease the operator-dependent variability, and you get much more reliable numbers. And then obviously the operator experience, you know, we are fortunate to have Regina doing Fibroscans, I think 15 years now, and EchoSense calls her if they have a new software or better device, they will want to bring it to IU. They ask her to use it, and then they take her feedback on, you know, is it going to be user-friendly and how it is operating in real world. So, so those are some of the quality metrics, and the other ones are, I told you, if there's somebody in the hospital with heart failure, it's going to increase the backflow, the liver stiffness would be elevated. In fact, some cardiologists are using Fibroscan to do it in the hospital and predict the risk of readmission in somebody with congestive heart failure. So not necessarily inflammation and fibrosis in the liver, but how congested the liver is that is increasing the stiffness. And you know, if somebody has a liver surgery and stuff, you can't take the liver stiffness as is because there may be some scar tissue in the region of healing. So I told you about CAP. What does it mean with regard to fat in the liver? Sometimes we have somebody who's been exposed to prednisone for a long time. They gain weight. They have, you know, diabetes, some fatty liver, and they are treated for their autoimmune, but liver enzymes are a little bit elevated. Now we are scratching our head, is this autoimmune not getting controlled, or is this fatty liver causing liver enzyme elevation? So we look at AST, ALT, they can be elevated in both conditions. We can look at the ratio, and they have diabetes, they have obesity. So this Fibroscan will tell us how much fat there is. So sometimes if we feel like, well, IgG is normal, they're compliant with immune suppression and been treated for 3 years, nothing much happened, no flare happened, and there is CAP is 350, we wouldn't necessarily put them through a repeat biopsy to see if there is inflammation in the liver. We would rather concentrate on diabetes, you know, fatty liver, GLP, whatever, to bring the weight down, to bring the fat down, and see how the liver tests improve before we go down the path. Maybe you have autoimmune hepatitis that is not under control. There is this one study that showed that even patients with autoimmune with MASLD, which is the metabolic dysfunction associated, you know, fatty liver, with and without fatty liver. Those with fatty liver had worse prognosis than without. So I think it is important that we address the fatty liver in addition to autoimmune, and CAP is very helpful in doing that. Now, liver stiffness is predicting the outcomes. So for a while, we were saying how much liver stiffness corresponding to how much fibrosis. Instead of that, we are looking at, okay, this is what it is, your liver stiffness is this, and your risk of having an outcome is this, once we treat you and we reevaluate your liver stiffness. In this study, this is a retrospective study, so they saw that if somebody has 8.5 kilopascals or higher, the risk of getting cirrhosis and poor outcome. So longer treatment is lower liver stiffness. This is another study where they showed that the longer you're treated, your inflammation goes down, and obviously your liver stiffness goes down. And also it is possible that the fibrosis is also reversing. So the longer you're on treatment, you would expect to see an improvement in your liver stiffness. Now, liver stiffness is also predicting the presence of varices needing treatment. We talked about it. Now, spleen stiffness would perform even better, either alone or in combination with liver stiffness. I wanted to share with you a recent patient we saw. Young woman, she presented with jaundice, itching, pale stool, dark urine. She had a biopsy in 2023, very strange. She had stage 3 fibrosis. MRI, MRCP was normal. Alcohol use was very insignificant. But they were stuck because ANA was negative, SMA was negative, anti-LKM was negative, IgG was normal. So she went around with no diagnosis, despite having all this workup, and she showed up with jaundice and itching. So we assumed that this was seronegative autoimmune, and we started her on CellCept, and you see the bilirubin increasing dramatically, liver enzymes improving dramatically, and that sealed the diagnosis that this was autoimmune all along. And this was very stark example of how autoimmune hepatitis can masquerade and fool many seasoned doctors, and autoimmune markers are not always helpful. So we even decreased their CellCept. So this was her first Fibroscan, 13.4 liver stiffness. As I told you, we are evaluating other devices. So these are the 2 other devices that we are testing. The numbers you see, 13.4 here, 11.9 here, 11.9 on the other one. So they're in the similar range, but they're not exactly the same. And then we brought her back. This was 35 days later. It improved to 11.8. So that tells us that this is the inflammation that resulted in the improvement. So over time, I would expect that 11.8, when it improves further, I would think that is the fibrosis that is improving. Right now, I think it is the inflammation. Generally, we recommend 6 months of treatment before we redo the Fibroscan, but we have a free Fibroscan through research. We can do it for free, so we can do as many times as we want. But this helps us in knowing that, how the liver stiffness is changing over time. So I am happy to, interpret your Fibroscan. You look at your own Fibroscan. Do you have 10 values? And is your IQR over median less than 30%? And if your ALT, IgG, and your long-term duration, think about that. And if your liver stiffness is less than 8.5, you're good. CAP less than 250, you're good. We didn't do the spleen stiffness here, but those with cirrhosis, we would like to do spleen stiffness. So that is how I would interpret your Fibroscan. And last but not the least, I wanted to talk about, Lord Lambert mentoring my daughter. This was the first AIHA meeting they volunteered. That resulted in our subsequent work and interest in autoimmune hepatitis. She published a paper with Craig, and now she's at UCLA, and she wants to pursue a career in medicine.